to the American Society for Stereotactic and Functional Neurosurgery podcast. On today's podcast, we'll speak with Dr. Kai Miller of the Mayo Clinic on surgical decision-making in epilepsy.
If we could kind of start with, maybe with the big picture. Dr. Miller, what is your general philosophy when it comes to epilepsy surgery?
So for me, the question of epilepsy surgery always comes down to what's called concordance. So concordance is a term that means agreement, but in this case, it means agreement between semiology, so the symptoms that you have before, during, and after seizures, and potentially auras in between seizures. The imaging that you get, so in particular, high quality MRI really can guide us towards lesion localization, but also PET and electrophysiology. And in this case, it would be EEG and MEG, although, you could, there's a secondary consideration of concordance that comes after we would do something like stereo-EEG. So that's a core philosophy for me in epilepsy decision-making. Sorry, I didn't mean to. Yeah.
So it sounds like in your practice, the pre-surgical workup does include PET and MEG. What other?
Frequently, yeah, absolutely.
What are your thoughts on mapping function and what kind of is in the scope of course, we talk about concordance and matching anatomy, physiology, semiology. And then, of course, it's a different discussion when it comes to dealing with eloquent cortex. So what are your thoughts on mapping function?
So there's the workup mapping of function is different than the workup localization of seizures. So my general philosophy is you start out with this question of concordance, and then from there, you navigate a decision tree. And I know it's a little bit uncouth to share my own stuff, but I don't know if I could give a plug for a paper that's really geared towards trainees for decision making, and it's called Decision Making in Stereotactic Epilepsy Surgery. What this was an attempt that I made after about 3 years in practice. I wanted to carefully articulate what the decision-making process is and what the interventions at the time that we did were. And it obviously field is advancing quickly and these things will change. But for me, we're navigating decision trees. So in this paper, we go through, you start out an epilepsy consultation, you do this workup where we have imaging like we've been talking about. We have mapping, we have MEG, these kinds of things. And then we go to multidisciplinary conference, we ask about concordance, and that drives us down towards intracranial monitoring if there's uncertainty, or towards definitive therapies. If there's something that's concordant and it's a lesion in a non-eloquent area, you go take it out. You might do hemispherotomies in special cases like Rasmussen's or hemimegalencephaly. And then you might do disconnection surgeries, that kind of thing. And sometimes you'll do a stimulator up front if your localization is just, it's generalized seizures. We have, different semiologies, different electrical sites of origin, and either there's no lesion on the MRI or there's many lesions and it's unclear what's what, and going after all of them would be too morbid. So this goes through that and it has visual examples of them. But that was my best attempt to really just articulate what the decision-making process is. You have epilepsy conference, right? So that's where neurologists and neurosurgeons and neuropsychologists and radiologists all get together, typically online now. And we talk about each individual patient. We ask this question of concordance, discuss whether or not we're confident in moving forward with something definitive, or do we need to do intracranial monitoring, or do we need more workup? And there can be a lot of argument in that. And particularly as a surgeon, I feel like you can get swayed by stronger or weaker personalities. And this isn't even personalities day to day for a particular epileptologist, but just the drift on that particular day. And so for me, articulating really well helped me do that. The question of mapping, right? There's two things. One, you want to find seizure onset, and two, you want to identify function. If you have like a lesion and you're in its agreement with the electrophysiology that you get outside the head, an agreement with your imaging, but it's near an eloquent area, that's the time when you would do something like a grid is usually a good thing then. And sometimes you'll use implanted monitoring with stereo-EEG or electrocorticography to define that margin separately from defining seizure onset, which you may already know because of concordance. So sorry, that was a long-winded, meandering answer to a straightforward question. I apologize.
It is a big topic too, right? And I guess kind of to narrow down the question, I wonder kind of what your approach is to when it comes to, I think one of the biggest questions that comes into epilepsy surgery is like, what do you do with the focal epilepsy coming from a dominant temporal lobe?
So for focal epilepsy and the dominant temporal lobe, for me, there's a couple of questions. Obviously, the most basic first question is going to be, is what we think dominant, right? So it's left temporal lobe and they're right-handed almost all the time. That's dominant temporal lobe. But in some cases, there's a little bit of ambiguity. And you had asked about how we determine dominance. Handedness is a good shorthand if we think they're left dominant because they're right-handed. They usually are, not always, but you'll want some secondary verification. If it's potentially right dominant, you do have the ability to do MEG and fMRI. But something else is, do they have, is an early symptom of their seizures language disruption? And sometimes that will just guide you into dominant side. How I think about how aggressive we want to be is dependent upon a few things. Mesotemporal sclerosis is a standard, it's a standard board's question. You look at the MRI, hey, there's a mesotemporal sclerosis there. And when we see mesotemporal sclerosis on what we know is the dominant side, we have to ask ourselves, is there still memory function being served by that? So there's a few considerations. And particularly, you'll have bilateral sclerosis, and you won't know in some patients. And then that has to be a nuanced discussion. And we've had times where we identified a left, what we thought was diminutive hippocampus, and went through the whole process of ruling out different sites with stereo-EEG, ultimately did radiofrequency ablation of the dominant hippocampus, which is a smaller lesion than either laser or open resection, and had some memory deficits. And then that moved us away, and unanticipated memory deficits because it seemed to be so diminutive compared to the contralateral side. So that the dominant memory is one of the tougher decision-making steps that we have. And this is just as far as mesial temporal structures go. Anatomically, in the dominant temporal lobe, as far as epilepsy, you have to ask yourself, is there evidence of neocortical involvement? So in my career, there's been when I started, lasers weren't a thing yet. And so was temporal lobectomy, right? Later lasers and temporal lobectomy, but then people would do selectives, and people talk a lot still about selectives, but I don't know. I think that in general, people are moving away from that. And certainly in my practice, it's selective means laser, basically. And then temporal lobectomy, for me, temporal lobectomy on the dominant side should be reserved for cases where it looks either based on imaging or EEG or stereo-EEG, like there's neocortical involvement. So a lot of times if you have gray-white blurring on the dominant temporal, anterior-temporal structures, then you may be looking at a temporal lobectomy over laser ablation. So the question you want to have is not how far back are we going to, should we do a less invasive open surgery versus is there evidence of neocortical involvement? And if there's not evidence for neocortical involvement and it looks like it's strictly mesial, then you may want to start with a laser because, of course, laser doesn't obviate the ability to do an open resection later.
Awesome. How do you decide then especially in that context where you're trying to differentiate the level of neocortical involvement, where to put your SEEGs not only in temporal structures, but when you have other focal or just kind of diffuse epilepsy pathology?
Okay, so let's say you have a focal cortical dysplasia, extratemporal. we run into this problem sometimes that there's borders with eloquence, and then we want something relatively in the dysplasia where we think the imaging border of the dysplasia is, and something that you may learn from doing open procedures is that you'll do a palpable margin where you feel the difference in the stiffness of the cortex as you do your resection of the dysplasia, and you find that really is a larger boundary in your postoperative scanning than you would have had based on your preoperative estimate. And sometimes you'll see it during your case just because you're fusing in and checking navigation. But we may want to find that with our monitoring. And so sometimes you're thinking about, well, where are seizures generated, but also what's the extent? And that can get tough because, when you start looking at things volumetrically, which we do with stereo-EEG, there's a lot of volume and there's a relatively small sampling corridor that we have with stereo-EEG. And because each of our stereo-EEG electrodes should be tied to specific hypotheses about where we think seizures are starting from, spreading to, or where we potentially treat with a resection or stimulator. Sometimes, people put in thalamic electrodes to stimulate and do test stimulation, not just to see seizures propagating into the thalamus. Every stereo-EEG lead should be tied to a specific hypothesis. And so finding the margin of where you think your pathology is, and the pathology in this case is not tumor pathology where we got to get it out because we don't want this thing growing. It's where we think the margin of the seizure onset and the seizure generation is. And so I've certainly had cases where we lasered a FCD in left frontal neocortex, got a complete ablation for what we could see visually. Patient continued to have seizures. We did an electrocorticography over top. We saw the extent went well beyond, in fact, into eloquent cortex. We then performed sort of a limited resection, but just knowing we couldn't go further because of eloquence, because it basically went into precentral gyrus in a way that, we couldn't map. And certainly for children, mapping considerations become different. But we use stereo-EEG to do task-based mapping, to do stimulation testing for a variety of things for function. So for language, particularly dominant side, and for movement, testing memory, and it is a difficult problem.
Yeah.
So you guys had asked me before about WADA testing. Mm-hmm. It can be difficult to do WADA testing on the dominant side. If you're doing it for language, it's great, right? So for those that don't know about WADA testing, it's where you inject an anesthetic into typically common carotid or MCA. And I'm certainly no expert now. I haven't done WADA testing. I'm not a vascular neurosurgeon, but what you do is you then look for deficits. And of course, looking for speech, you can see that very well. The problem is if you're looking for memory and they can't talk to you because you've injected that side, it's very difficult to test. But at a time when WADA testing can be useful, and I think this is something that we look at now, is where you're wondering if all of the memory function, or if a significant amount of memory function is sitting on the dominant side, you can do an injection in the non-dominant side and then see what their hit is. So a lot of times we want to know, we think that if there's a lot of sclerosis in the hippocampus, it's probably not holding any memory function anymore. But you can actually test that by doing a WADA on the opposite side and seeing if they have residual memory function. Or if you think that, the right side is not needed for memory, you can test it with WADA. But it's difficult to directly test the dominant side as an independent object using WADA because of the whole speech protocol. Some people will try to give patients things to remember, but it becomes tough.
I see.
So, yeah, Miller, we talked about concordance. I think one of the difficult things from what I've seen in fellowship is what do we do with discordant information about a function, especially when it comes down to, we found our seizure focus, and now we have two different modalities telling us different things about language or memory.
Well, I would say so when two different measures agree, you're good. When two different measures disagree, you have to ask which you think is more solid and if there's anything further you can do. Okay. And for things like speech, it's difficult to, if you have a piece of information that says speech is not here and a piece of information that says speech is here, and you go after that anyway, and you're wrong, that's a very difficult situation you put that patient in. And your involvement, you have some direct involvement in that. I think if they're discordant and it's related to memory, especially if they're younger, the pediatric brain is more plastic, right? So they recover better. You may say, well, we had these discrepancy and there may be a memory hit, but we at least think that there is a lot of this memory function that's also represented somewhere else, and it will be able to take over and reorganize this function over time, or remap this function over time. For language, that's a tough one. And if we have very, very young kids, I may do something in the dominant language side, when the kids are, 3 or younger, 4 or younger, knowing that it can come back on the other side than most people. I think that for memory, adults tend to tolerate it less. So, but what I would say is if you have discrepant information and language is what's concerned, you want to err towards being conservative, I think. And you want to get more tests, right? So you have something we didn't talk about is TMS. So you can do TMS to try to causally interrupt extracranially. You have MEG, you have your fMRI, and then you'll have your results from intracranial mapping. And we have sort of an off-label protocol where we just measure passively, and then we have people engage in tasks with us, and we can do passive mapping there. That tells you everything that's involved, but not everything that's essential. So some of the sites that map positive there, they may map negative with stimulation mapping, and we'll say, hey, we think this is involved with speech, but when we shut that area down with electrical stimulation, they were still able to do things. So it may be a safe area to go, even though it is a speech area. In adults, it becomes more difficult because their ability to compensate and their plasticity over time, it just isn't what it is for kids. The other thing is with kids, the urgency, it's urgent, SUDEP, so sudden death and epilepsy it's a risk for everybody. And that's always should be taken into account. But I think that the urgency to intervene is sometimes more for younger individuals because ongoing seizure activity, even when it's not when they're not actively seizing, can really impair their cognitive function, disrupt their intellectual development, but also their social development and the way that their childhood goes. And so sometimes we may be a little more aggressive in children, understanding that even a small setback that we give them, and it should be small, you should have some sense of that, is going to be that's going to be a lot less morbid than the issue of ongoing seizures. Okay, and then there's also some nuance about anti-seizure medication. So if you can reduce the anti-seizure medication load in anybody, that helps them cognitively, but in children, it helps both their cognitive performance and also their development. So the urgency in children to treat because of the developmental curve that they have over their lifetime, cognitively and socially, it's a little more urgent in children. And their ability to bounce back is different than adults. And so seeing that boundary as a different thing, the eloquence versus seizure onset boundary in young people is a different consideration than it is in adults.
And in that context as well, does your threshold change between the adult and the pediatric population when it comes to resection versus SEEG and like see if there's resection, or even BBS, RNS, or some of the non-invasive approaches? How do you differentiate, or how do you differentially look at those two populations when deciding how aggressive to be?
Well, I think we're a little more likely to be aggressive in children, like I said, because of the developmental benefit of seizure improvement, and the fact that they're getting a cognitive setback because of ongoing seizures. And this can happen to adults too, where they have a cognitive setback, but it's just that's not in the context of the developing brain. You don't see adults you see them have a decline, but it's not that, they're on with children, the normal trajectory that a child may be on if they didn't have seizures might look like this. And then you see them starting to fall off of it just because they're not having those developmental steps that they would have because of the ongoing seizure activity. So we would be more aggressive. For how aggressive I am in terms of doing something, let's say degrees of aggressiveness are most aggressive is a massive disconnection, less aggressive is a focal resection, less aggressive than that would be laser where you spare the corridor, and then less aggressive than that would be neuromodulation. Look, I think neuromodulation tools are starting to really expand our ability to address different kinds of seizures, right? We started out with neuromodulation of cortex and some subcortical structures. That was really the paradigm when NeuroPace came online. And then later we had DBS come online, targeting anterior nucleus of the thalamus. And now what we're seeing is that, well, we can identify different seizure networks, and we can identify where they come cortically, but also if they're widespread, we can see where that widespread seizure onset converges on relatively narrow thalamic targets that we can put an electrode in. And the mainstay right now, and this might change in a couple of years, is you have anterior nucleus, and we think about this for limbic circuitry, okay? So if you're going to do DBS for bilateral mesiotemporal epilepsy, and we may do RNS with two in the hippocampus, but if you're going to do DBS for that, then you're looking at ANT. I use a slightly different ANT trajectory, which I think allows us to get a little more frontal coverage because we're on our way into the anterior nucleus of the thalamus. So we also have ANT a lot we think about for frontal. If you have perirolandic, sensory motor seizures or general seizures, we're thinking centromedian. And then we think pulvinar, not just we used to think about it for posterior quadrant epilepsy, so occipital lobe, but also parietal and temporal neocortex. These are structures that we target in the medial pulvinar. So parietal is sort of medial dorsal, temporal is ventromedial in the pulvinar. So pulvinar, CM, ANT, those are our big targets, with the understanding that on our way to ANT, if from posterior trajectory, we often get some of the more dorsal thalamic projections to frontal cortex. Sorry, that was a long answer again to a short question. I don't need.
No, it's super helpful. Yeah.
Thank you. We talked about a little bit how the reasons that we would be a little bit more aggressive for pediatric patients with epilepsy, kind of the road ahead of them, and what benefits we would see over time. Are there any adult populations in which you would be a little more or less aggressive? Like thinking about things like lesional versus non-lesional epilepsy, or seizure severity or frequency?
Sure. So there's a few considerations, and understanding that these can be sensitive topics. I think that you do have adults who are extremely impaired, who have less day-to-day function than many other adults. They may be nonverbal and wheelchair bound, and the ability to reduce their seizure frequency at the cost of a deficit that may or may not be apparent with them would cause me to be more aggressive. An example of this, and that's because the quality of life that they have is very directly linked to the ability of caregivers to help them. And so if you can stop them from having generalized seizures and drop seizures, you want to be more aggressive. And so the rapidity with which we'll go to something like a corpus callosotomy, while we will do this in people who are very high functioning, and my colleague Jamie Van Gumpel, I think has done this very elegantly with a lot of our adult patients, and I do it with some of our adult patients as well. But we'll go to a corpus callosotomy to try to prevent drop seizures in particular, I think very quickly if they happen to have cognitive delays. So you may do more aggressive disconnection surgeries for people who have more significant deficits, just because you improve their quality of life if you're improving their seizure frequency to the degree that people can take care of them better. Separately, if you have, one of my mentors where I did my fellowship in Utrecht in the Netherlands, a guy named Peter Hasselaar, he told me something that, that really stuck with me. In my whole early life or early adult life as a scientist, I focused on electrical signals measured from inside the brain. And I went to a place where they'd done a lot of really good work in the Netherlands for my Van Wagenen fellowship, and also for a fellowship 3 years before that. And this guy told me, he said, we do all of these things. We have these wonderful scientists that we work with electrophysiology, but very small advances in imaging, allowing us to see a lesion, have made a much bigger impact for patients than electrophysiological innovations. And for me, that's, it goes a little bit against what my philosophy had been, my life philosophy had been before. I mean, my first goal is always going to be do the right thing for the patient. But I had all these toolkits that were built for electrophysiology. But I really think that that's true. The advent of 7 Tesla imaging, the advent of new sequences that allow us to see subtle lesions, has that anytime you have a lesion, you must test the hypothesis that is where seizures are starting from, and then your indication to go in to do something that's resective and more aggressive that may give them a little bit of a deficit, or even sometimes a more significant deficit. My confidence in seizure freedom, especially for extratemporal epilepsies, goes way up if there's anything I can see on the MRI that's concordant with either their symptoms or their electrophysiology. And these very subtle findings, oftentimes those would be patients who there may be some discrepancy between electrophysiology and semiology, and you want to go to stereo-EEG ahead of time. But yeah, I'll be more aggressive if there's something that's lesional, especially, not especially, I mean, you temporally as well, you want to be more aggressive, right? And classically, we've been very aggressive in the anterior temporal lobe as surgeons, and I think that we'll continue to be. There is something that's interesting about being aggressive and the different types of things that we do, though, and that is using lasers. So what I've found so far is that we don't see vascular injury related to heat from lasers. And it may be that you can do that. So I don't want to say, hey, this never happens, and then have somebody do that. But we seem to be able to burn through areas where you have perforating vessels without injuring those vessels because they carry the heat away. And in the case of mesial temporal lobe, this means we can get higher in the anterior medial temporal lobe and get this area that's called piriform cortex further. And that seems to be a route of transmission between mesotemporal structures in the frontal lobe and to some of the white matter tracts that base the frontal lobe that may wind back into insula and into other areas. And so there's actually an ability to be aggressive anatomically safely that we can do with lasers that we could not necessarily do open. And so I think that's kind of an interesting nuance. It's a little bit different than what we're talking about, but I think that that is a useful thing. We
can put some links up to the piriform papers associated with the podcast.
Yeah. And I think I have some, if folks are interested in that, I have sets of slides I made that show some of the imaging, but I haven't, somebody should write it up at some point. Anyone who's viewing the podcast, if you're interested, temporal lobe ablations and relative strategies for those, email me.
Kind of to put everything all together and kind of bring it back to the patient. What is your approach in kind of counseling patients through, I think despite all of our best imaging and everything together, we can never make our certainty 100%. How do you walk patients through the risk and benefit when it comes to epilepsy surgery, especially on the dominant temporal lobe?
Yeah. So I think that everybody has a different bias, right? Our bias as surgeons tends to be how patients do in the short term because we make sure that they tolerate the surgery safely. And we tend to be biased to say, well, this patient was seizure free when their seizures may come back later. But at least in my own case, I also tend to be biased by the fact that when I see them, if they have a deficit, I see them, the long-term benefit of seizure reduction versus the long-term cost of deficit. I don't have the same view as the neurologist, where the neurologist will say they may have a deficit, but their lives have improved dramatically because their seizure short. So everybody has different biases. I think it's important to have solid communication between the neurologists and the radiologists and the neurosurgeons. And I try to convey that to the patients. So I'll say, this is our group consensus. This is my personal bias. And I will tell them, I think that it's a bias. If it is a bias, especially if it's a little bit different than the group. And then I'll just be honest with them, right? For me, the golden rule of neurosurgery is the same as the golden rule for life, where you should only recommend and do on other people what you think would be reasonable to do with your own family, provided that you are honest with them about the fact that you're not facing the same decision-making situation that they are. But if you're recommending something different than the consensus of the group, you better be very honest with both the patient and also let the team that you work with know that you may have given them a reflection of a different set than the consensus of the group is, because I feel like I always have to be honest with patients about every element of care. But we all carry our own biases, and sometimes we're right and other people are wrong, but a lot of times other people are right and we're wrong, and we just have to be honest about that. And there are times when I've certainly, let's say, done temporal lobectomies when if it were my own family, I would have attended towards laser, and then I presented it to the patients those ways, and they came to the right decision there, and they did extremely well. And then there's been other times where the group, particularly for the right non-dominant temporal lobe, I think that it's not, the right-sided temporal lobe is not a vestigial organ, so you should preserve it when you can. And so right temporal lobe epilepsy for me doesn't necessarily mean temporal lobectomy, but for a lot of surgeons it does. And those surgeons oftentimes are much further in their careers than I am, and have seen how well people do. So I don't want to say that that's the wrong thing, but I also think that innovations in multi-target laser allow us to get better results for mesotemporal lobe epilepsy than we were, let's say, 7 years ago. And so there are differences among surgeons, and there's differences amongst different types of practitioners. And so there may be different rights, okay, and sometimes there's different kinds of wrongs. But if you wouldn't do it to your own family member, right? If you wouldn't clip a basilar tip aneurysm on your own family member, you shouldn't do that on somebody else's family member, right? So that for me, that I try to use that to guide how I think and what I do. But we're all humans. As long as we're doing the absolute best we can for these patients as if they were our families, then that's the best ideal I feel like I could strive to. And so for temporal lobe, especially dominant side, you got to ask yourself where that function to seizure improvement or seizure freedom boundary lies. And I'll tell you, if there's extra, if there's neocortical abnormalities, you also don't want to be on the side of doing a laser when it's clear that there's separate seizure onset zones that may have kindled the hippocampus on that side. You should take that neocortex with the mesotemporal structures, even if it's dominant side, because that's the best chance for seizure freedom for these patients. And most of the people that will present to you surgically, then they're not going to get seizure free with medications. In fact, if they would, they shouldn't be seeing you to begin with.
I think with that's the perfect closing for us. Do you have any other questions, Robert?
No.
Awesome.
Thank you. That was great.
Thanks. Well, it's an honor to get to talk with you guys today, and please reach out for any reason. Anyone that's watching or listening to this, especially when you're in your training, it can be useful to go and see different things. People are welcome to come here and contact me for any reason. I won't put my cell phone on the internet, but time you meet me at a conference, I'll give you my cell phone. I've been very lucky to have been the recipient of a lot of cell phone numbers of a lot of people that are senior to me, who I still call if I have any uncertainty or if I'm concerned about a complication that may arise or has arisen. When it comes to patient care, we put our pride away. And also when people call me, I try to just be as good and human as I can and tell them what I would do. I think that these relationships help you be a better doctor. So when you're in your training, reach out to people. People should be, and within functional neurosurgery and pediatric neurosurgery in particular, I think the openness to have people come observe and see different things is very high. And I think it's been very useful. Having been on both sides of it, it's been like a game changer for me.
That's all for this episode. Thank you so much for joining us. Stay tuned for the next installment of the ASSFN Podcast.